My name is Alan Ellsworth. I'm a professor of pharmacy and family medicine at the University of Washington. I've been lecturing in the patient management course at medX since 1982. The patient management course or pharmacotherapy course is a two-quarter course covering the breadth of pharmacotherapy. Double covered. A number of the lectures in adult medicine and pediatric medicine cover similar topics, but this is sort of focused on more the drug component, the pharmacokinetics, the pharmacotherapy, the ins and outs of specifically using the drugs. It's important, of course, because of all the modalities that providers use, drugs are sort of the number one. There's more drugs used than there is surgery or counseling or other sorts of things. If you come down to the actual therapeutic, here we go, what trick is going to be used most often? It'll be drugs. When I was a student at the University of Utah in the early beginnings of clinical pharmacy, I was told that pharmacy is changing and you will be the one that runs the therapeutics. The doctor will be the one that runs the diagnostics. And so you are going to be the drug expert, or you are going to get more drug therapeutics, lectures and experience and accumulated hours than the physician. You should become the drug expert. So I was young and idealistic, and I bought that. We're still preaching it today to the pharmacy students today. You're the drug experts. Take over. My first job was in a small town in Iowa where the town's doctor was a resident from Cedar Rapids, 30 miles away. A faculty doctor would come out a couple times a week and touch base and review charts, but they were pretty much on their own. We did a couple of vasectomies I was the anesthesiologist. The resident was a surgeon with a phone call, Craig Lindeson. The doc would see the patient and he'd come into the pharmacy, which was one of the exam rooms, which was remodeled into a pharmacy, and he'd hand me the chart and he'd say, this kid has an ear infection. And the next patient, this guy's blood pressure isn't quite as well controlled. We'll need to jack up the medicines a little bit. And the pharmacist would be the one that did that. So I heard it in school, and I took a job that allowed me to do it. And in 5 years in Iowa, in a small town, I sort of embraced it and lived it and loved it and thought it was the right way to go. But had no family, no relations, no connections to the Midwest. It had connections to mountains. And had family in the West, so I looked for my opportunity to get west. In 1981, I took a job with the Department of Family Medicine in their family practice program as a residency as their clinical pharmacist. And somehow got connected with Ruth Ballwig. And she asked me to teach in this patient management sequence. And so over the next several years, she coordinated and I taught the bulk of the lectures in the patient management course. I had practiced as a clinical pharmacist in a primary care setting, and so I had patients, and I could give actual patient experiences and utilize those to teach. So I also have some opinions or some biases about things. You know, pharmacotherapy is broad, lots and lots of options. You're going to treat hypertension, you're going to treat a cold, you're going to treat diabetes. There's lots of different options to do it, and I had some biases or some opinions that I was usually pretty free about sharing. Sometimes it had to do with a lot of the stuff that was used was pretty much witchcraft and you should stay away from it. And you could do just as good with a Jolly Rancher and an ibuprofen tablet and some water without all the other hullabaloo. Or sometimes Big Pharma was trying to push a particular product and I was against Big Pharma and tried to make it practical and simple and easy and not get tied up with all the drug company advertising. I worked at sort of clearing that stuff out of the Family Medical Center in the Department of Family Medicine. There was a clinical pharmacist in the center. He could be the interface between Big Pharma and the residents. If there was important things to come through, then the pharmacist would let it through. And if it wasn't important, then it wouldn't be passed through. Certainly, some learning does occur when a drug rep meets with you and describes a new drug, et cetera. There can be some learning. But their job really is to eye you, form a relationship with you, and that sells drugs. And if that didn't occur, Big Pharma wouldn't be doing it. I was in this big city and I had this rural bent to me. I'd rather live on a farm, and have a couple of cows and some chickens, get out of the rat race, so to speak. But pharmacy is such that they cannot bill for clinical services. Just barely coming around. This year there's been some legislative changes, and it'll change, but it's the same promise that I heard back in 1975 at the University of Utah. The only way you could practice clinically as a clinical pharmacist was to be in a big city with a big health system which would allow you to bill, and they didn't really care about your billing because it didn't make any difference. It was such a small piece of the pie. So I began taking care of the chronic diseases in the family medicine department with the residents. The residents are there only a couple half days a week, faculty sometimes even less, but problems come up every day. And if there's a person there that's continuous, they can do a lot of that stuff. And so I became sort of the person that ran the chronic diseases, whether it was anticoagulation or heart failure or diabetes. You know, I would be the one that would do the teaching and the management. And they'd see their docs. Their docs were still their doc, but I was sort of doing the scut, so to speak. The docs were having all the fun. After 25 years of being a clinical pharmacist, I wondered, geez, I wonder if I could make some changes. So I proposed a program where you could take some rotations and take some learning, and learn the practice of medicine and get certified to practice medicine, and then you could then bill. And if you could bill, then a private practice doc could buy you or use you in a small town. So that's what I did. Sort of flew under the radar. Ruth and her crew let me sort of bend the rules a little bit. I took the morning classes one year. I took the afternoon classes the next year, still working. And then instead of spending 12 months doing clinical rotations, they allowed me to do 18 months of doing rotations because I did them a little bit half-time. I was able to get it done. And I continued to practice as a PA at the University of Washington Family Practice Center. It sort of changed my role a little bit. Instead of being the pharmacist now, hey, wait, you can bill? We'll give you patients to see. But I still had this inkling of heading rural areas. Did some locums work on Highway 97 to Nasket and Okanagan. I investigated a former resident in Bellingham. I investigated opportunities with a former resident in Sultan, and ended up joining the Sky Valley Family Medicine Group as their PA in Sultan. And well, I've really enjoyed it out there. In my career at the UW, which is a great research institution and a great academic center of learning and a great model of patient care, and I've fiddled with all three of those areas. I've published and made it through to professor, and I've taught classes and have coordinated classes for over 30 years. Still, the most fun for me is really patient care. That's the most fun. I think the reason I like to work with patients so much is that I like to think that I'm really needed. That if I'm not there, things aren't going to go on. As a PA, as a primary care provider, people depend on you. And they don't want to see anybody else, they want to see you. And they'll put off their heart attack a day to see you the next day. As we've moved from Sky Valley Family Medicine, a small private practice, to Evergreen, which is now a big conglomerate, there's changes in the bureaucracy and the things we have to do and the way we manage things. But I like to try to think that I'm the same, that people can say, okay, no, he's still the same guy. It doesn't matter, there's more carpeting, there's more this, that, and the other, but he's still going to do the same thing. Yeah, that kind of thing is what gets you up in the morning. You can get up in the morning for that.
I have one more question. Why a bow tie?
I started wearing a bow tie at the University of Utah when I was a student, and I perpetuated it all the way through. There was a couple of years where I wore a long knit tie, but still most of the time I would go with a bow tie. As I finished up my quarter this last year, probably 30 or 40 students were all wearing bow ties for the last day of class. You've got to be confident to wear a bow tie. You can't wear a clip-on. You've got to tie it yourself. And you know that people are going to recognize you, and so you've got to be bold. The students that I've worked with in the medics program over the years they're a more mature bunch. They ask better questions. They ask searching questions. They're thinking about how they can apply it. I had an opportunity to teach and practice side by side with some great University of Washington medics PAs. Ruth Bawa, Henry, Terry, Grace. they gave me all these breaks, which has just opened up a whole new thing for me. I'm working way harder than I did 10 years ago. I could have cruised, but I'm really enjoying it much more, the patient care responsibilities, et cetera, that they provided for me. I hope I've left a little bit of influence and a role model for others to follow, but I actually really appreciate the opportunities that I received more.
Thank you very much, Al.
Okay.